The present technique demonstrates the senior surgeon's preferred method for segmental labral reconstruction using an iliotibial band autograft in the setting of a prior failed labral reconstruction. The most common reasons for a failed labral reconstruction are residual impingement, often secondary to cam under resection, capsular deficiency, adhesions, and traumatic injury. Notably, the patient who underwent surgery in the present technique required a second labral reconstruction due to capsular deficiency. Following the establishment of anteromedial and anterolateral portals, the prior reconstructed labrum is assessed and found to be insufficient. Following diagnosis, debridement and removal of the reconstructed labrum is performed using an arthroscopic burr, flexible radiofrequency device, and arthroscopic beaver blade. It is important for the acetabulum to be completely cleared of bony ridges and soft tissue. Here, you can see the labrum has been successfully debrided and the acetabulum has been adequately prepared. Next, the insertion of the iliotibial band autograft labrum constructed per the technique described previously is begun. First, the medial anchor is placed at the 3 o'clock position on the acetabular face, just superior to the psoas recess. The graft is then shuttled through the mid-anterior portal and down to the acetabular rim using this suture. A second anchor is then placed in a similar manner laterally at the 9 o'clock position. The free suture end from this anchor is inserted into the suture passing device and the labrum is pierced. The labrum is then secured to the acetabulum using alternating half-hitch knots. Additional anchors are then placed at evenly distributed intervals along the acetabulum to reduce the newly reconstructed labrum. The labrum can be secured with a suture anchor in either a looped or pierced-through fashion dependent upon the needed eversion of the labrum on the acetabular rim. It is essential to assess this positioning to aid in restoration of the suction seal. This process is repeated until adequate restoration of the suction seal is confirmed on dynamic exam as demonstrated. The hip is slowly brought into varying degrees of flexion as well as internal and external rotation to assess for adequate repair of the labrum and maintenance of the suction seal. The head-neck junction is viewed from both portals and multiple angles to fully assess the reconstruction. Here, we identified the suction seal had not yet been restored. Additional anchors were placed to better secure the labrum to the acetabulum. A second dynamic exam was then performed, and the suction seal was confirmed to be excellent. Thank you for watching our technique video, and we hope it is beneficial for your practice.